Thank you. Luke Evans.
Thank you, Chair. Secretary of State, would you set out your understanding of the issue of senior doctors and the pension issue?
Yeah, my understanding is that, I mean, first of all, what I'd say about pensions in healthcare is that they are generally, I think we can say we have a generous system of pensions. I think 9 out of 10 sort of healthcare workers across the board, not just doctors, join that pension system. As you know, it is voluntary for them. But my first sort of interaction with this particular issue, where in certain circumstances, and it's typically a doctor, senior doctor, because they obviously, as you all know, are the highest earners typically in the NHS. They can reach their thresholds. Either it can be the allowance, and especially linked to the taper rate. I think has been historically has been the biggest issue, the taper of that annual allowance, and or they can have a challenge with the total lifetime allowance. But my first sort of time I properly looked at that actually was not in this role, it was when I was Chancellor, and I properly looked at that, and I was persuaded then by my predecessor that something had to be done, because it was having an impact. I accepted it was having an impact on work, the number of hours worked, and that was crucial, and I accepted that we had to make change. And then that was implemented by my successor as Chancellor. And that change, I remember it was increasing, the taper was considered, certainly by the previous Secretary of State, and my understanding was that was the main issue, and we increased the point at where it kicks in, I think from £110,000 to £200,000 a year salary. And that has had I think a dramatic impact. I remember what the department said at the time, that something like 96% of GPs and doctors thereabouts were inside that 200,000 level. So only a very few were left after that change in terms of being affected by the taper rate in a negative way. It did cost the Treasury $2.2 billion. I think that was the estimate at the time. And that's important because that change had to be made for everyone, not just health workers. It had to be made for everyone for equality reasons. So whether you worked in private equity or you worked in the NHS, if you were at that income level, for example, you received the benefit of that. So it was in that sense, it was a very expensive change. I think it was the right change. And now, and just to finish on this, because the pension issue is important, is that we are still looking at what further flexibilities there could be to make sure that pensions are not getting in the way of work effort.
Well, it hasn't escaped my notice of your previous role before you stepped into the Health Secretary role. And I see it as a politician, being on the doctor's side and a politician's side, the balance between getting taxpayer value, because doctors are well paid compared to the rest of the situation. But to be frank, we are facing a huge backlog, and we are now getting senior doctors who are choosing not to work because of the worry about their pension and overpaying, especially with inflation now. One solution when this happened similarly was the judicial system, and there was a system put in place for judges. Is that some consideration that you have had, or in conversation with the Treasury, to think about having an unregistered scheme? Is this something that's crossed your desk?
We are. I'm aware of that scheme, and we are looking at further flexibilities. What those ultimately are going to be, because of joint work between ourselves and the Treasury. And if there are tax changes, clearly that is ultimately for the Treasury. But the Treasury does take this seriously. I think one thing that does play on my mind, as I always am, we be very open about this, is that when you're talking about people, you talk about senior doctors and some of the highest paid, not just in the NHS, but in society. Anyone earning more than £200,000 a year, I think I'm right in saying it's probably like 1% of the highest paid 1%, 2% in society. And as you know, in terms of workforce and paying fairly for the NHS workforce, there's a lot of demands on the budget, and whilst it's right to think about what changes might be necessary for some of the highest earners to create the right incentives, I also want to make sure it's well balanced with some people that are like nurses, for example, that are earning much more average level wages.
I will definitely concede that, and that's why I opened the question with it. I guess the balance is there are when it comes to healthcare, there are only certain things that certain people can do because they are, by definition, the experts in what's needed. We have such a big backlog, the likes we have never seen before. So it's what point in your mind, and you may not have the answer yet, but it's a useful steer, is what is the compromise to determining paying that money for the experts to make sure that there is no disincentive to get that backlog dealt with? Are we dealing with a principle position or a practical position, or something in between the two?
We want to be, of course, we want to be practical. So, for example, one thing that we've done, I think recently, was published guidance for NHS trusts, because they are ultimately the employers of these doctors' different trusts, around flexibility. So, how the option for them, in many cases, to give salary in lieu of pension contributions. So instead of an employer's pension contribution, they could offer the doctor the equivalent amount, but in salary, of course, it's tax, it's salary, but the doctor still gets that income. Now, some trusts are doing that. Other trusts are not, and that's why we issued guidance recently to sort of make it clear that it's something that we are, certainly at the centre, are happy with, but it's ultimately the trusts or the employers. We want to make sure they understand they have these flexibilities, and I think where that is happening, it is certainly helping.
Thank you. We've dealt with last one. I was going to say, so we've dealt with the chair talking about people coming through the bottom. I've just dealt with the people at the top. We heard about the middle people. Would you consider, or are you considering mandating list sizes for GP? 1,500 patients per GP, 2,000 patients per GP, to try and control the workload, to manage the difficulties that we heard about in the evidence given. If not considering that, what other considerations have you made about managing the day-to-day workforce?
Well, what the important work I think that's been done broadly in that area just very recently, and something I'm taking incredibly seriously, is what we call the Fuller stock take, Claire Fuller's recent report, commissioned by the NHS on broadly on primary care, and she looked at just this. More than this, but this whole issue of what we started the session with today about the workload for GPs, the flexibilities for GPs, even the issue that the chairman referred to at the start about continuity of care. She actually had a lot of, I thought, very sensible stuff to say on that. So I'm looking carefully at that report. I know the NHS, who commissioned it, has taken it very seriously, but I'm also looking, using that report, what further changes we need to make in primary care to make sure it's better, both most importantly for patients, but also it's a better work environment for the GPs.